to cover. We'll be using the chat box function today. You can open and close this by going to your toolbar and clicking the icon marked number 1, which will appear on the slide on your screen in a second. Please use this to ask any questions or to post any comments. All participants have their cameras and microphones off for the duration of today's event. If you need to leave the webinar, you can do so just by pressing the leave button. Lastly, please be aware that today's webinar will be recorded and shared online for those unable to join us today. Thank you, and I'll now invite Alison Serran, Senior Improvement Advisor, to start the webinar.
Hi everybody, thank you so much for joining us today and welcome to the launch of our Acute Prescribing Quick Guide. We've got about 400 people who've registered for this webinar. I know lots of those will want to watch the recording afterwards, but it just shows how much interest there is in working in this area, in this subject. The Acute Prescribing Quick Guide is a new resource to support primary care teams to get started with making improvements in the area of acute prescribing, and especially when you just might not have the time or capacity to work through a long resource, a long toolkit. So in this webinar, we're going to introduce you to the quick guide, which has been published today, and we're going to hear from 4 teams who've tested some of the tools and the resources in the guide. And then we'll also introduce you to a new program, our Pharmacotherapy Quick Start program. But just to get us started, I'm going to hand you over to Dr. Graham Gold, who's a GP and part of our clinical faculty. And Graham's going to give you a little bit of background to our work on acute prescribing. Thanks, Graham. Well, Graham, we can't hear you. I think you might be on mute.
Yeah, here I am now. Sorry, guys. Good afternoon, everyone, and welcome to the webinar. So why focus on acute prescribing? As you can see, we've got 3 main aspects to this. We need to provide patients with good access to their usual prescriptions, and we do that through repeat prescribing. But on occasions, they will need an acute prescription. So they're going to get that in a consultation, but also by putting in special requests. And there needs to be a safe way of them ordering this and the GP reviewing and considering what will be provided. And we know from data through our collaborating practices and through your own experience that the workload produced by acute prescriptions is huge. So we're trying to improve that by using quality improvement measures and working with the team. NHS data in England has shown that certainly around opioid prescribing, pharmacists and GPs working together have probably reduced the number of deaths related to opioid prescribing by 350, or over 2,000 harmful events have been reduced by good team working. Next slide, please. It's important to understand what an acute prescription is. And the simplest definition that we've come across that's useful to use is that an acute prescription is any prescription without a serial or repeat mandate. So that would include any prescription that's occurring, as I've already mentioned, in a consultation, but also these special requests that come in on a variety of routes into the practice on a daily basis. Next slide, please. So to give you a bit of context as to why the acute prescribing toolkit has been developed, we have the toolkit that's been available online for a while, and now we have the acute prescribing guide that is going to be described to you this afternoon. And this has been under development based on the policies for the GMS contract, which came in 2018, and the Memorandum of Understanding, which came in 2021. And this led to the development, which is ongoing, of pharmacotherapy services. And I know a lot of you are involved both in employing your own pharmacotherapy services and those contracted via your health boards. The serial prescription toolkit was developed from collaboration of 53 practices in 2021, and I'm sure you've all used that over the years, and hopefully will continue to use that. And we're recommending that you use that as part of your review and development of acute prescribing. So moving patients from acute prescribing to repeat and serial prescribing where appropriate. The acute prescribing network began in 2022 and involved 77 practices, and we developed the acute prescribing toolkit. So that's available now on the iHub, and within that you will also find guidance to access the acute prescribing quick guide. So from that we've come up with 7 steps, 7 change ideas that we're recommending that you consider for use in acute prescribing. So I'm going to hand over now back to Alison. Thank you.
Thanks, Graham. So the acute prescribing quick guide we've just published today, so it's now live on our website, and one of my colleagues will be popping the link in the chat so that you can go and have a look around yourselves. But these next couple of slides just take you through a bit of what to expect when you access a resource. There's not many of them because it's we've really tried to keep this focused and keep it as short as possible. So it's a single web page, providing an online resource to help you get started with acute prescribing improvement. So the first screenshot here is showing you the top of the page, and you can see that links to other resources and pages are highlighted in blue. And the other screenshot is of the table of change ideas. The main focus of this resource is around those 7 change ideas that have been tried and tested. For each idea, you can see there's a kind of summary, an overview of what the idea is about, and then some links to anything that's a really key document or a really good example of a practice or a team who've used that idea. And some of those links you'll find do take you into the bigger acute prescribing toolkit. But we really hope this is a good way to get started and to get into the bit that interests you the most, rather than having to work through the whole toolkit step by step. So once you click through some of those links, these are a couple of examples of what you might find. They will open almost all in a new tab. There's just one download, which is the first screenshot here of the standard operating procedure template. And then they're quite short resources to look through. So the other screenshot here is a learning summary from one of our practices from the Acute Prescribing Learning Network. And it's a 1-page summary of their project and the learning from that. And then you've already seen this graphic when you joined the webinar today. This graphic is a real summary of those change ideas. And it's something you can download as well from the quick guide page. So if you want to stick it on the wall, email it to somebody who doesn't even have time to review a whole web page, but might have time to have a quick look through this, then that resource is there for you to use as well. And we really hope that you'll find the quick guide useful and that will help you to get started, if you haven't already, with some acute prescribing work. And we'd be really glad also to hear any feedback you have about it. As the guide is quite a quick thing to look through, we've focused most of the time in this webinar on hearing from teams who've already tested some of the ideas, either working with us in the Acute Prescribing Learning Network or more recently in our Primary Care Access programme. And so I'm delighted to introduce our first presenter, that's Ryan Richardson from Oakwood Practice, and who's going to share their acute prescribing improvement work with us. Thanks, Ryan. I wonder if we've lost Ryan. What we might do, we'll get somebody to work out where we can get Ryan back. But what I might do in the meantime is we'll skip through Ryan's presentation and we'll come on to some ideas for you about getting started. I'll pass over to my colleague Gareth to do that, and we'll see whether we can get Ryan back to speak to us just after that. So Gareth, are you there and good to go? Fab.
Oh, I think I might be back.
You are back. Ryan's back.
have
Wonderful. That was
I don't
perfect
have an
timing for
option
you
for
to
slides, but,
disappear.
I might need someone to do my slides for me because I don't have an option to take control, unfortunately. Smashing. Smashing, thank you. So, hello everyone, my name's Ryan. I'm one of the pharmacists that works in Easterhouse Health Centre in the northeast of Glasgow. And I'm here today to talk a little bit about a project that we've done around antidepressant acute and repeat prescribing. Next slide, please. So I've only got 5 minutes to talk about this, so it'll be very much a whistle-stop tour, and I won't go through all the information on the slides because it is available and you can read through it at your own leisure. So I think the first thing to think about when we were coming up with the project was, what did we want to work on? So what is your service need? What do you want to focus on? So for us, we had thought about a few different areas. And we'd looked at some of the STRU data that was available, and from that, antidepressants was one of the kind of areas that we thought, right, we could give this a go. We also used a GGC database tool, which was developed by Andrew Morgan at Central Team, and that allowed us to track month on month what was happening with our antidepressant acute and repeat prescribing. So it accounted for about, antidepressant acutes accounted for 14% of the monthly acute workload. And we thought, right, we'll get started with that. And we wanted to have a pharmacist-led approach initially, but we didn't really have the pharmacy resource to fully support that. It was really just me in the practice at that time. We didn't have any technicians or support workers. And so we came up with a sort of practice protocol and a way of dealing with acute prescriptions in the practice. So this is maybe a bit of a pain, but could someone jump to Appendix 2? It's near the end of the slides. Thank you. Just back one. And again, yeah, that's right, thank you. So the way that we dealt with our antidepressant acutes was that when practitioners received a request for an acute antidepressant, they had to do a review and then mark the review date in the pharmacy text. So this would allow the patient to get this on repeat up until the point at which it was due another review, and then when it was due for a review, it would then go back to a practitioner and they would do the review again and then mark on the next review date. Instead of having patients left on acute prescriptions indefinitely, where they're issued month and month and month and no one actually really deals with the patients, and antidepressants tends to be one of those areas where that happens a lot. Patients get left on for a long period of time and they're not reviewed very effectively. So if we can jump back in the slides, please. So we thought we would have a process around that, and go forward one slide, please. And we set our aim, so have a good clear aim of what you want to do. So we wanted to reduce our overall proportion of acute antidepressant prescriptions relative to repeat antidepressant prescriptions, improve our care of patients on antidepressants, improve job satisfaction, and then at some stage have a pharmacist-led clinic. Next slide, please. So we thought about our barriers to this. So the main one was, where we're going to actually have the time to do this. Would we have the time to do all these reviews? Would the staff in the practice be able to adapt to this new kind of process and this way of managing one particular group of medications? Then looking more at the pharmacist aspect, we have quite different styles of risk management. Would that fit in? Would patients be satisfied with the pharmacist doing the review? And we kind of worked around those as we went through. Next slide, please. So we got our training sort of put in place from the practice manager and the assistant practice manager with the admin staff, so that they were up to speed. I done a few sessions with my GP partners just around improving my knowledge on antidepressants and just really dealing with certain situations. And we implemented the protocol. And then eventually we added in April 22, we added in a pharmacist-led clinic, which was initially focusing on the reviewing of patients who'd already been reviewed, and then building on to acute prescription requests as well. Next slide, please. So what we kind of seen as we went through was a really, really great improvement in our prescribing. So we had a 70% reduction in our acute antidepressant prescribing, with a 58% increase in our repeat antidepressant prescribing. And we also had a general overall reduction in our acute prescribing by 40%, which I think really came out of as maybe thinking about other drugs that we were prescribing on acute and how could we tighten up those or maybe improve the way that we're dealing with those. So naturally that just kind of fell into place. It wasn't that we ran specific projects for them. although we have since ran a few other projects. But it was just an overall awareness with everyone that when you're doing an acute prescription, should I be leaving it on acute? Should I be reviewing it? Should I be moving it over to repeat? And then I've put in some data here just about an evaluation of the clinic. So I think that was the important thing as well. We had a month-on-month rolling evaluation of our data, so we could see that we were having real-time change, and that was very good at keeping everyone engaged and motivated with the project. And then next slide, please. So what we've seen with the barriers that we had initially was that they all just really melted away. We had a very, very smooth transition, and the concerns and fears that we once had really weren't there once we got started. Next slide, please. And then we had there's some general feedback from the GPs about how it was a great service that we'd ran, and there was also some patient testimonials as well that we had, which I've not included in here. And then the next couple of slides, which I'll really not talk through too much, is just really the data, so you can look at these things at your leisure. So the sort of change with the acute and repeat prescribing over time, so that was a kind of starting point and our end point. And then the next slide, please. And then just an overall evaluation of the changes that I made through the pharmacist clinic to medication that was increased, decreased, or not changed. And the next slide, please. Is just a breakdown of my clinic and the referral outcomes, so who did I refer patients on to. And I believe that's the end of my presentation.
Thanks very much, Ryan. Thanks for that. That was quite a whistle-stop tour, so well done, especially given the technical issues. Ryan's slides will be made available after this for anybody that wants to look a little bit further into that data. So for the next section, hi everybody, I'm Gareth, I'm one of the improvement advisors. And this actually leads on quite nicely from Ryan's section. And I want to talk to you just for this next section about where to get started when it comes to your change ideas and what you're going to do. And Ryan mentioned at the start of the percentage of workload that the antidepressants are making, the volume of acutes that the practice in Easterhouse we're working with. So this little section is just about understanding that data. Ryan already made mention of the Scottish Therapeutics utility and how they used that data to help focus in on what change idea they wanted to use. Excuse me. So STU, Scottish Therapeutics Utility, is available to all GP practices. It's provided by a trusted third party. It's a piece of software that amalgamates and displays clinical data. There's a lot of kind of clinical reports down the side. You can see here from the screenshot on the left-hand side, there's respiratory, there's chronic pain. For the purposes of acute prescribing, the two that we're probably most interested in are the dashboard report and the repeatable acutes. The dashboard provides a rolling 18 months of the volume of acutes, repeats, serials, etc. that the practice is producing. And the repeatable acutes essentially identifies patients who've had the same item issued on acute more than once over a 3, 6, or 12-month period. You can see the little drop-down menu that has a 3 months, 6 months, 12 months there. There's also drop-downs for BNF chapter and BNF section. I'm sure any of you that have done some work in acutes will be not surprised to know that in a lot of cases, the CNS chapter is the one that's generating a lot of workload when it comes to acute prescriptions within primary care. So for the purpose of helping to interpret that repeatable acutes data, we came up along with our DMBI team with a Pareto chart tool. Pareto chart just helps display the volume of workload pressure per BNF chapter in the repeatable acutes area after you transcribe the data over. We've provided that resource online. It's available in the quick guide in the acute prescribing toolkit. And a lot of the teams that we've worked with and are continuing to work with have used it to help develop what area they're going to focus their change ideas in on. So I'll just give you a quick look. When you download it, you'll get this page as the first page within the Pareto chart tool. Just lets you know how to enable it, how to populate your data from STU over to a little bit of transcription. It takes maybe 10, 15 minutes. And what will happen afterwards is it'll give you what we have here, a nice example of Pareto chart. So I mentioned CNS is often the one that crops up. You can see here it's second, and it's providing, in this specific case, around about 21% of the acute prescription workload. But it's actually the skin chapter, emollients and such like, that are providing 28%. So between those two BNF chapters, you're actually accounting for about 50% of the repeatable acutes workload within the practice. So that might be where you want to look to tackle. It might be the case, as Ryan alluded to, about time pressures, how many whole-time equivalents, what staffing do you have. Maybe it's more realistic to look at a smaller area first, test some ideas, and then see if those ideas apply to the larger areas when you want to move on. There's no right and wrong way to do it. It just depends what the conditions are like in your team to make some change. And as Ryan showed with his data, collecting some data over time after you've started your change idea will let you know if what you're doing is making a difference. But you want to make sure that it's not an intrusive industry collecting data. So having a little bit of a decent data plan will allow you to keep that focus. We all know it's hectic, whether you're in a general practice and a pharmacotherapy hub, anywhere in between, and there's different priorities, different projects going at different times. Being continually collecting that data, be it weekly, monthly, etc., it'll let you know that there's still focus there on the work, and it'll also allow you to perhaps pivot if you're not getting the results or if there's unforeseen things that are happening. So that's just a very brief whistle-stop overview of where to get started when it comes to understanding your system. And with that in mind, I'd like to now introduce another speaker, Catherine Harvey from Edinburgh Health and Social Care Partnership, to tell us about some of the work that they're doing.
Hello, can everyone hear me? Yeah, okay. Hopefully this will work. Yeah, okay, so I'm Catherine Harvey, as Gaz said, and I'm a pharmacist working in the northwest of Edinburgh, and I'm the project lead for the acute prescribing project we've got right now for all over Edinburgh, which I'm just going to speak a bit about. So why are we doing the acute prescribing project? Well, as we know, the Healthcare Improvement Scotland launched their acute prescribing toolkit in 2022, and Edinburgh City had 10 GP practices involved in the pilot from January to May. And so we wanted to utilise the toolkit and make it a project as part of our efficiency work that's running this financial year. And we all know that process and acute prescriptions is part of the pharmacotherapy workload. And we've got some GP practices in Edinburgh that are doing about 40% of their prescriptions are done as an acute. Just to put that into perspective, they kind of say that you want to aim for 20% of prescriptions on acute and then 80% on to repeat. So it can be a large part of these practices' daily workload. So we want to reduce that. So the aim of the project is to obviously reduce the number of acute prescription requests. And we've done this through targeting specific BNF sections using STU, Scottish Therapeutic Utility, which Gav's just spoke a bit about, and his acute prescribing toolkit to produce a sustained change before March 2024. And we've set out a kind of target of a minimum of 2, but maximum of 3 BNF sections. And we're looking for at least a 20% reduction in acute items per BNF section. So Ryan showed from his project there that should hopefully be quite achievable. So how we've used his toolkit is basically we use the Pareto chart template on the toolkit, which shows you top BNF chapters, and then you can break down that further to show your BNF sections. And this kind of helps practice teams have a focus on what BNF section, what kind of medication is their main acute that's coming through their practice, so they can have a focus on what they're going to do their kind of protocol on, or what they're going to focus their project on. So that's where we kind of thought would be good to target and get the whole team, everyone across Edinburgh kind of getting involved. It's quite easy to sort of replicate that. And his toolkit certainly helped me develop the whole kind of project as well. This is just a screenshot of Stu, which Gareth has kind of already shared, but the BNF chapter here is central nervous system, and the BNF section is antidepressants. So it would be 20% of the antidepressants acute prescriptions we'd be looking at reducing. And just even this patient here, you can see they've had fluoxetine once every month for the past 4 months. So that is a repeatable acute. So you might be thinking, how can we get that onto repeats, or can it be put onto repeats? This is just a screenshot of like the Pareto chart, as Gareth showed. And as you can see, as he said, CNS is top for this practice, then infections, skin and gastro. So then we got our teams to kind of break it down a wee bit further. Possibly don't want to focus on infections, as you're probably looking at antibiotics as being an acute prescription anyway. So this is just a screenshot of skin being broke down. And you can see that it's the topical corticosteroids and the barrier creams that are top for the skin chapter. So that might be where this practice will target. So that's the kind of helpful tool that's part of the toolkit that we've used in our project. So what we're currently doing is we've done all our Pareto charts, and now we're having meetings with our whole practice teams, including GPs, pharmacy team, admin team, getting everyone involved, and we can sit down and decide on what targeted BNF sections we want to do as part of the project. And then we want to produce protocols to get these from acutes onto repeats. So the kind of data capture that we proposed for the project is there's 3 data points, and the first baseline data will be in at the end of July coming up, and that's where we'll implement the first protocol until September. We'll keep that going, but then September we'll implement the second protocol and so forth, and with the end of our project being March 2024. So help for our practice teams, we're currently set up a Microsoft Teams channel for our pharmacy teams to share protocols, vision searches, Pareto charts. We're going to have like monthly question and answer sessions. We've got project leads for each locality to help when needed, and then attend GP clusters as well, so that everyone's involved, and obviously using his acute prescribing toolkit when we find it necessary. So as you can see, we've not actually done anything of our projects yet, as we kind of start with our baseline at the end of July and moving on to March, but hopefully we can get some good data for everyone come 2024. Thank you.
Thanks, Catherine. That's really great. And I'm sure lots of people will be interested to hear about how the project's going once you get started. We try to, as we're launching a quick guide today, we try to keep our webinar pretty quick. So please carry on using the chat box for any questions. If there are too many to answer just now, we'll pick them up afterwards and we'll put them into a document. So the next thing is I would really like to introduce you to a new offer that we've got coming up. So Catherine's obviously talked about the project that they're doing in Edinburgh, which is great, but we know that not everybody has got that kind of support locally to do that. We really hope that for lots of people, the quick guide is going to be enough to help you get started independently. But if that feels a bit daunting, you're not quite sure where to start, or actually if there's something else you want to focus on, we're also offering the opportunity to work with us to get started. So a lot of people might know that since October last year, our team in primary care has been working in our primary care access programme to kind of help primary care teams over a sprint, that's a 7-week sprint, to improve an aspect of access. What we found is that around 20% of the teams in that programme have worked on pharmacotherapy projects, and we're actually going to hear from 2 of them in a few minutes. But to build on that work, we're now opening expressions of interest for a focused pharmacotherapy quick start programme. So it will not fix all your problems, but is maybe a good way to get started, to get some focus time together, and to work through something. And it will be working with one of our improvement coaches. So to understand what's happening at the moment, your data, current systems, identify a first step as a change to test. And then we can help you to understand whether that's working the way you want it to. So our first cohort for the programme will start in September and run throughout September and October. And you can choose to work on any aspect of pharmacotherapy, really. So it can be acute prescribing, but it could also be something else that you think you'd like to do some work on. So polypharmacy reviews, hub working, high-risk medicines, or anything else you can think of that you'd like to get started with some improvement work. So my colleagues have just shared in the chat the link to the program page for this, the join the program page that gives you a bit more information. And there's a button there to click through if you'd like to complete an expression of interest form. For the September start, we're asking those to be completed by the end of this month, by the end of June, if possible. But to give you a bit of an idea of what might be possible in quite a short time frame, we've invited a couple of teams who've worked with us in the Access programme to present. And so I'm going to first pass you over to Helen, who's going to tell you a bit about the work her practice did with us in the Sprint programme. Thanks, Helen.
Thanks, Alison. I'm just checking everyone can hear me okay, because my headset's just broken.
Yeah, we can hear you fine.
Just trying to get control of my slides. So yeah, I'm the Communications and Patient Engagement Manager at Riverside Medical Practice in Lothian. So I'm not clinical, obviously, so I think my presentation will probably have a bit more of a patient experience bent to it, and but hopefully that will still be useful. I'm kind of not going to talk through the slides perhaps so much, but just talk you through a bit of a timeline of the project and how we got involved with it. As Alison said, we were in cohort 1 of the Access programme, and I think probably drew to a conclusion of that in, I don't know, is it kind of maybe December or something, but we've definitely taken that forward, and now we're kind of just starting more quality improvements just left, right and centre, so it has been great for us. I guess as the background why we got involved with the programme, until recently we were running a predominantly same-day system for patient-requested pre-bookable GP appointments, and what I could see was through the complaints process and our feedback processes, patients were having a lot of challenges to book either an initial medication review after initiation or booking a subsequent review when they were asked to do so by the GP. And that was obviously leading to patient frustration, a lot of repeat phone traffic and staff abuse. You know, we had a lot of patients saying, you know, I'm really perfectly happy with my medication, I just need another supply of it. You know, this is kind of creating a kind of repeat cycle and frustration. And what we saw happening as a result was, I think, an increase in acute prescription requests coming in through our online order forms, as patients, because they couldn't get a review, were just thinking, you know, I'm wanting my next, you know, batch of medication, and I'm just going to put a request in for it, see what happens. And I think GPs were pragmatically, rather than letting patients go without, they were issuing, you know, a very short-term acute prescription and again asking people to book in for a review. And I think that just kept creating this endless cycle of, you know, increasing number of very short-term prescriptions and patients continually having to phone in to try and book that review. So we wanted to provide a way so for people who were entirely happy with their medication to get their next supply of it easily and safely. And we wanted to test the use of online medication review forms to do this. And how we went about deciding which one to start testing with. I think my initial was, let's just do all of them, but I think the advice of the HIS team was really valuable here. So we did a week's manual tally where we asked all of our GPs to record what have you issued a kind of short supply on acute this week, which would have benefited from a review, and to categorise it into different medication categories like antidepressants, painkillers. We found, as we probably imagined, that antidepressants, painkillers and HRT were our top 3. I think rather than diving in and, you know, doing our highest volume categories, we decided to test HRT first. And at that point, I think the GPs had issued kind of between 6 and 10 acute prescriptions that week that they thought would have benefited from review. So then his team got involved, came into the practice, which was really great, and we really mapped out on post-it notes our current process versus what we thought a new process could look like. And I think that really helped us to kind of close off every single little loop where a patient could kind of get lost or stuck. We then validated it with our GPs and our admin team, the practice management team. And we also talked to our community pharmacies to get their agreement that they were happy to issue a 6-month supply off the basis of 1 acute prescription, so 2 lots of 3-month supply. And this was at a time of, you know, continued HRT shortages. I think in the future we're hoping to do it as a 12-month supply after the patient has a review. So the patients are given advice when they're initiated on their HRT, you know, that if they're happy, they can fill in the form, or if not, you know, the old way of booking a GP appointment for review. So we were really thinking about what I call putting speed bumps in the patient's road rather than road signs. So rather than kind of saying, oh, you know, we've got this form, you can fill it in, we kind of really, by putting the review form on our prescription landing page, it really forced all HRT requests to go through there and to fill out the form rather than put it through as an acute prescription request. So the form screens out people who aren't happy with their medication, and it's essentially for people who are broadly wanting to continue with it as is, and lots of, you know, questions for GPs to check that you know, things like their BP and any symptoms they've been having. So how it works is it gets booked in with a GP 1 to 2 days after the patient submits the form in order to be able to really rapidly respond to any red flags like high blood pressure or any problematic symptoms. And actually we have seen the form being really useful for that. And I think a couple of GPs have ended up doing urgent referrals for symptoms that patients had flagged up on the form, but, you know, they'd, on questioning about it, they said, oh no, I wouldn't have come in to book an appointment with you about this. So that's had a unintended but positive impact, I think. We tested it with 1 GP first to make sure that the system worked. And I'll just try and change my slides now. Oh no, maybe I don't need to. So I think in terms of results, the call room were really happy with the change. So they felt they got something to offer patients, you know, who were calling up on the day saying, you know, asking for a review. So there was just less patient frustration on the phone. The GPs were very receptive and really happy with this process. So what we're essentially doing is, you know, reducing people booking in 15-minute appointment review slots and reducing those that are happy with that to a 3-minute acute prescription slot when GPs actually review the form. Got really good patient feedback. So I think 89% of people said the new process was or might be better. They hadn't quite made up their mind yet, but quite a low number of people saying, you know, they didn't like this process. I'll change my slides now, I think. Oh no, sorry, I think my slides have changed a bit, which is why I keep flicking back and forth between them. So issues we had were a few patients brought up the issue of a lack of online access. So we have made a hard copy version of the forms available to them. More people than we thought said that they didn't have their own BP monitor at home. So we've made one available in waiting rooms for them. And a screen for privacy. There's a few issues around kind of briefing staff. I think in testing it with 1 GP, I think a lot of the other GPs got wind of it and started getting a bit concerned. So that was something for us to consider next time. I think as with all these things, a few things cropped up that we had never considered. So people making acute prescription requests who were on HRT for reasons not associated with menopause, and they were then getting sent a questionnaire essentially saying, please fill out this about your menopause symptoms. So just that was something for us to be aware of. And also I think we didn't really factor in the fact that people were now entering a lot of like baseline health data on forms like, you know, height, weight, smoking status, which is obviously beneficial to be added into the patient record and coded in addition to the GP making the prescribing decision. So I think we've definitely increased the number of HRT reviews we're doing a week from something like 6 up to 20. So whereas there were, beforehand about 6 that were being issued on quite a short acute prescription that could have benefited from review, we're now getting about 20 people through and actually having, a proper review and then getting initiated on a 6-month supply, which will reduce their, the amount of times they're coming back to us. And yeah, as I said, we've now really kind of quite rapidly moved on. It's given us the confidence to move on to SSRI reviews. So we've already started trialing that. It works in quite a different way. So it's more of a clinician initiated online medication reform that helps people move from acute to repeat prescribing, as a lot of other people have been talking about in this, but really the same principles have been used. And I think doing the HIS project has just helped us to feel more confident about that and having a bit of a process to go through there. Those are all my slides. I think I'll just pop up a bit of patient feedback at the end. So we actually captured the patient feedback on their HRT review form. So that was a good way of capturing their thoughts about the process rather than going back to them and trying to elicit it at the end, which sometimes is quite challenging. But yeah, really good feedback, and that's nice to see.
That's fantastic. Thank you, Helen. I can see there's that started a bit of activity in the chat, so you might want to pop over.
I'll try and answer them
see
now.
if you any questions to answer. That would be great. So I'm going to then pass over to our final presentation for today, which is Stacey, who's also going to talk about a project that her team worked with during the sprint program with us. Thanks, Stacey.
Hi there, I'm Stacey Ross. I'm the practice manager at Carrick Medical Practice in Maybole. We were part of cohort 1 as well. As part of our cluster, we all individually worked on something different. We knew that we had a problem with our acute prescribing, so we decided to have a look at that. Sorry, I'll just start my slides. So our plan was to reduce the number of our acute prescriptions by 20%. We knew that by doing this, the acute prescribing figures would drop, and our repeat prescribing and our serial prescribing would increase. The plan was to involve the whole practice team, including all clinicians, pharmacists, or mental health practitioners, and admin team, and we plan to measure our progress using STU and EMIS web searches. So what we did was the same as everyone else. We did our data collection using the STU tool and input data into the Pareto chart. We involved the whole team, tried to map the ideal process. There were some challenges with workload pressures. The 7-week sprint was a bit challenging, especially at the end of November, beginning of December. So there were some time constraints. Some of the problems were maybe locums working within the practice, unsure of any new processes we were putting in place. And we collected the data before and after the sprint. So as predicted, we managed to reduce the number of our acute prescriptions for antidepressants, analysing the data using STU, EMIS web, the Pareto chart, which was run in November, we reran in February just to evidence the number of acute prescriptions. And it showed that we actually decreased our acute antidepressants by 27.4%, which was a huge amount. We found from doing this, we found that we could make small changes to other acute prescriptions. For example, dressings and diabetic items that were put on acutes that didn't have to be put on acutes. We made the decision to move them over. We do need to update our operating procedure to include, we're now getting the same as what Ryan was doing. Our pharmacy team are going to be doing the antidepressant reviews when patients are at the end of their serial prescribing run, when the treatment summary comes through. So they're going to start doing the antidepressant reviews as well. We're going to continue to monitor all and acute antidepressants, monitor all acute prescriptions as a whole, focus on other areas. We'll probably look at other acute items. And with the change in the acute prescribing, our pharmacist now has more time to focus on polypharmacy reviews and other pharmacotherapy work. She's actually started doing like weekly clinics, which has been really good for the likes of respiratory and depression reviews. This here's just a little visual of just showing that first one there is our CNS chapter. So that just showed that definitely something we had to focus on. And the next one was endocrine, which we found was a lot of items that didn't have to go on acute, such as test strips, lancets, sharps boxes. So now we've got an operating procedure whereby our admin staff just automatically move anything that's been inadvertently put onto acutes. So our change ideas were we created a SOP for antidepressant initiation, whereby instead of putting onto acutes, our GP puts on with an issue limit of 1 and gets the patient to make their antidepressant review, and they can increase the time if they decide, or increase the dosage or whatever. Once the patient's been on it is stable, they can get moved onto serial prescribing. And we do have the protocol in place so admin staff can safely move any items that they see on acutes onto repeats. What worked well, involved the whole team really, but that was the main thing. And the thing that helped was the Stu data, just enthusiasm of the whole team, pharmacy and admin team, taking ownership of areas, communicating with everyone. And we also had an existing medicine management work done in Ayrshire and Arran that we do every year that kind of ran alongside it, that kind of helped kind of move it along a bit quicker. So I think that's all. That was just the pressures there, the challenges with the workload pressures, and top tips were utilise everyone's skill set and just tackle a mix of quick wins and longer term changes. That's it really. Hope that's
great, Stacey.
Give you a
Thank you
whistle
so
stop
much. Thank you. It's really good to hear from teams who've worked in a kind of in a shorter time frame to get through that first step and get started. So that just about brings us to the end of our webinar for today. So I really just want to thank everyone who's presented, Ryan, Catherine, Helen and Stacey, who've given up their time to share some of their work today. It's been really great to hear about it, and I really hope that's inspired some of you. The quick guide is available now, so it's been published today, and the link has been in the chat, so please go and have a look and at the resources there. And if you're interested in working with us in the Pharmacotherapy Quick Start programme to get a bit of coaching support, please go through to the Join the Programme page and complete that expression of interest form. As we said at the beginning, this webinar has been recorded, so the recording will be made available and the slides to everyone who's registered, so you'll be able to have a closer look at some of those presentations later on. If there are any questions that haven't been answered, we'll also make sure we pick those up and create a Q&A document for you to have a look at later. But thank you everyone for joining us today, and please do keep in touch. Our email's there, and we'd love to hear about any work that you're doing, or if you have any questions about any aspect of the acute prescribing work. Thank you.